So the title you had given was Nuss procedures, but I'm going to talk about both pectus excavatum and carinatum. So Nuss and Bromson procedures together, let's say. I have nothing to declare. Chest wall deformities, congenital chest wall deformities are fairly common structural deformities, as we all know. And the pectus deformities are the most common of them all. About 95% of the congenital chest wall deformities are indeed pectus deformities. Excessive growth of the lower costal cartilages result mostly in sternal depression, causing excavatum, and sometimes in sternal protrusion, and we call that carinatum. Let's start with excavatum. It's also called funnel chest or sunken chest. It's the most common chest wall deformity. It has a male predominance. It can be symmetric or asymmetric. It can be familial. It can be associated with Marfan syndrome, and mostly it's associated with scoliosis. The patients are usually asymptomatic. Sometimes, rarely, they have symptoms, but mostly this is a psychosocial problem.
Korkut, sorry, may I ask you to speak up a little bit louder, because you're hard to hear.
Okay, so this
is better.
This is better. Okay, thank you. So this is mostly a psychosocial problem. The patients have a negative body image, and they have a low self-esteem. Actually, the first repair was done for pectus in early 19th century, in 20th century, and the classical approach is open repair, as we all know, right sternoplasty and its modifications. In the last almost 2 decades, we have the other option, minimally invasive repair, or as mostly it's called Nuss procedure. And the major indication is actually cosmesis, as this is a cosmetic problem rather a physiological problem. There are various indices. The most popular, most common one is the Haller index. Do we really need to use them to decide whether we should operate a patient or not? In our practice, we don't really use them, because as this is mostly a cosmetic problem, you cannot reject a patient only because his or her Haller index is not high enough, for instance. So that's why we don't really care for the. I know in some countries they have to take care of this, take care of it because of reimbursement problems, for instance. We don't have a problem with that, so we don't really care for the indexes. So in the late 90s, in search of a less invasive and more cosmetic technique, Donald Nuss, he's a pediatric surgeon from South Africa, but he lives in the United States, of course. He described this minimally invasive repair technique of pectus excavatum, and it's in many centers it's been replacing ravaged sternoplasty. Actually, it's quite popular. So our experience have started in 2005. Professor Yüksel was our head of department back then, and he was really interested in this subject. So he initiated our program. We did our first Nuss procedure in 2005, and then first Bromson procedure as early as 2006. And Marmara has slowly, or actually rapidly, has become a referral center. And in the last 17 years, we've performed over 2,000 cases, both for excavatum and carinatum. Professor Yüksel is retired now, but he's still actively working in private practice. And in Marmara, we go on with the procedures. Nuss procedure, or minimally invasive repair of pectus excavatum, is actually a remodeling of the anterior chest wall by employing the retrosternal metal bar. It's a thoracoscopy assisted intervention. Actually, you don't use thoracoscopic instruments, but you use the camera to follow the procedure, not to give harm to any tissues, any interthoracic organs. The advantage of it is that instead of a big incision on the anterior chest wall, you have a smaller incisions on lateral chest wall. You don't need to resect any cartilages. You don't resect anything. Blood loss is quite minimal, and the operation time is really short when compared to right stenoplasty. When Donald Nuss described this procedure, he is still actually using longer bars with 2 stabilizers on both sides. But Hans Pillegard from Denmark, Aarhus, who is really another expert on this subject, he's also retired now. He's shortened the bars and started using 1 stabilizer, as shorter bars seem to be more stable on the chest wall. The longer bars tend to rotate more. So we prefer to use. We started with long bars, and then we modified our technique, seeing Pillegard doing his procedures. We now, since from the beginning almost, after like 1 year, we shortened our bars too. So what do we do? What do we do on the preoperative evaluation? Actually, at the beginning, we were doing everything: pulmonary function tests, CTs, echocardiograms, skin tests, etc. But now, routinely, we almost always only have 2 X-rays, posterior, anterior, and lateral, and then, if needed, we do the others. Sometimes patients come with the other tests done, actually, but we don't do the others in every patient, let's say. So the procedure is the patient is in supine position. We use a single lumen tube. In some centers, they use a double lumen tube. I know that, but we only use a single lumen tube because we use CO2 insufflation to visualize the mediastinum better. And we use a 5mm lens, a 30-degree optical 5mm lens on the right side. Retraction of the arm is avoided, not to cause any injury, especially on the plexus brachialis. So you can choose any of these positions. The aim is to keep the arm away from the lateral chest walls. You can hang both arms up, or only one arm up, or you can raise the thorax of the patient, as you see on this diagram. But we mostly elevate only one arm on the side of the thoracoscope. We tend to use bigger ports and a bigger lens, of course, but now we go on with a smaller lens, so our ports are smaller too. Maybe that reduces the pain also. And as I said, we always use a 30-degree optical lens, as it makes easier to visualize the pericardial fold to dissect through the anterior mediastinum. So this is a video of a practice of Excavatum operation. So we mark the lowest point first, and then we decide where to go through the line where we're going to place the bar. And we make while one of us is making the incisions on both sides, the other surgeon bends the bar. Of course, we have a template. First, we bend the template, and then looking at the template, we go on with bending the bar. And this third incision is for the lens. This is the way we go on with the CO2 insufflation. The patient is intubated with a single lumen tube, as I said. So the lung is not deflated, but rather compressed with the CO2. Also, the mediastinum is pushed forward with the CO2, and then this is the introducer. It looks like a sort of a sword, and you slowly dissect the tissues between the sternum and the pericardium, and then you go out from the other incision. You tie a ribbon at the end of the introducer, and then you tie the banded bar to the ribbon and then pull it through the tunnel, and then rotate with those instruments. You rotate the bar. And then you place the stabilizers either on both sides or only on one side. And if you need to bend the bars, the tips of the bars a bit more, we have those hand benders. It makes it easy to bend the tips of the bar on the patient. We don't have to take the bar out and bend it a bit more, but with the hand benders, you can do it while the bar is placed. And then we fix the stabilizer and the bar to the muscles, not to the ribs, with PDS sutures. And then we remove the CO2 through a catheter, suction catheter, and then we close our incisions. If the deformity is asymmetric, you can always place the bar in an oblique position. It doesn't have to be a horizontal always. If the deformity is asymmetric, you can make a double hump on the bar, as you see here, and it may help to have a better anterior chest wall. As I said, we use shorter bars, shorter than the bars that Dr. Nuss is using, as shorter bars are hard to rotate, and placing the stabilizer closer to the entrance of the bar into the thorax prevents the rotation. See, the stabilizer is on the anterior chest wall. It's not on the sides of the chest wall, but it's on the anterior chest wall, so it's more stable. But then if the bars are too short, they may fall into the thoracic cavity. And especially if you're placing two bars for the correction, the second bar tends to loosen up and fall into the chest wall. And it's really difficult to decide if it's fallen on the chest x-rays. So if you suspect of a bar in the thoracic cavity, you need to have a computerized tomography to see if the bar is inside the cavity or not. There are different companies. In Turkey especially, we have a couple of local companies producing bars. So thinner bars are preferable, maybe, to reduce the pressure and pain. And some companies produce smaller bars for younger patients, because sometimes if the patient is younger and smaller, the stabilizers are too big for them. So it's a good option to have smaller stabilizers too for younger, smaller patients, as they are less traumatic. So in the postoperative care, we do not really do much. There are no drains, no catheters. Patients go directly to the ward. We only have a chest X-ray postoperatively, and patients are on, of course, painkillers. We use PCA for the first 2 days, and then we go on with Epidural and Tramadol routinely for the first week. And we want the patients to go back to full activity as early as possible. Of course, we may see some complications in the perioperative period, early period, or during surgery. Of course, it's always possible to lacerate the heart, perforate the myocardium. Pericardial laceration is more common. If there are adhesions, pulmonary parenchyma can be lacerated, of course. Intercostal artery bleeding is possible. Rima bleeding is possible, and even rib fractures are possible if the anterior chest wall is too rigid. We may see that in all the patients, actually. And there are some later complications: wound infection, cellulitis, seroma, and bar rotation or dislocation, or even the stabilizer dislocation, as you see in this X-ray. Metal allergy is always possible. That's why we use titanium bars now. And insufficient correction is always possible, of course. Best results are obtained in symmetric deformities, but it's also, we may also have good results in asymmetric patients too. And it's possible to have good results even in the adult patients. We operate sometimes patients as old as 40, 50, rarely, but we do that. This technique works after failed Ravage 2. The ideal age is around 15, but as I said, you can always do it in the later period too. Up to 3 bars can be placed, and we keep the bars bars in place around 2 years, but especially in older patients, we may keep them up to 4 years. These are some examples from our patients. You see a 6-year-old boy here that we used 1 bar for the correction, and then this patient had 2 bars, a 14-year-old guy, and this guy a bit older, 19-year-old, and we corrected his deformity with 3 bars. As I said, it works after failed Ravage 2. These 3 patients are Ravage. They had Ravage before. This 9-year-old boy had Ravage 3 years before, and we corrected his deformity with 1 bar. 18-year-old male patient had Ravage 4 years before, and we corrected his deformity with 2 bars. And this one, a bit older again, 25-year-old, had Ravage 9 years before, and we corrected his deformity with 3 bars.
Okay, why? Can you go back 1 slide? Why should you start doing a Ravage at a 6-year-old boy? What happened that? Is that your standard or?
No, these are not our operations. These are not our.
Okay.
They all are operated in other centers.
Okay. So your age group is after puberty or before puberty?
Yeah, after puberty.
Oh, after puberty. Okay. And there's another question from the audience. Fabian Dörr is asking, do you see any indication for epidural anesthesia?
At the beginning, we use epidural anesthesia in around, I don't know, let's say 50 patients, but we had 2 patients having a respiratory arrest. That's why we decided not to take the risk and use it anymore.
Okay.
I know in some centers they routinely use that, but as we had some bad experiences in a couple of patients, we decided to leave it, but it's possible, yes.
Maybe we can discuss this point later together with Roland and Sönke as well.
Yeah. Should I go on?
Sure, sorry.
Thank you. Bar removal is the second part of this correction method, actually. You place the bar first in the first operation, and then you have to remove it. That makes 2 operations for 1 correction. Of course, it's performed under general anesthesia. The previous incisions, luckily you use the previous incisions, so that makes it a bit more cosmetic. And if only 1 stabilizer is used, and it's possible to open only 1 incision, the side where the stabilizer is, but we have experienced that sometimes there are bony tissues, bony structures going around the holes on the bars. So it's better to be on the safe side. We prefer to open both sides, even if there's only 1 stabilizer. We did it only from 1 incision a lot at the beginning, but then decided not to do it again. And of course, you have to unbend the bar if it's needed. If it has a big curve, you have to unbend it to remove it. This is a short video of a bar removal. You see our older incision. So on both sides, this patient had 2 bars. You don't have to remove the stabilizer if it's only 1 stabilizer. You can remove the bar together with the stabilizer, as you see here. Sometimes there are a lot of fibrous tissue covering the bar. You see, you cannot remove it. We try to pull it out, but it's not possible. So you have to unbend it a bit. And on this patient, we realized that there was a thick fibrous tissue going through through the hole at the end of the bar, as you see here, a thick fibrous tissue. So that's why it's better to open the side where there's no stabilizer to make the procedure easier. So you pull it out according to the curve. Can be challenging sometimes, as I said before. Sometimes the bar is covered with bony tissues, and you may have to use even a chisel and a hammer to break those bony tissues, or you have to use some rongers to bite those bony tissues to release the bar and to be able to remove it. As you see, we try to bite the bony tissues, and it was not enough. In this case, we had to even use. Sometimes it's more difficult to remove the bar than to place the bar. We have many patients like that. That it's more difficult to remove the bar than to place it. Actually, you see, in this case, we even had to cut the rib. Sorry, cut the rib a bit together with the bar because it was impossible to remove it without doing it. The bar was embedded in the rib. So cosmetic results in this procedure, in Nuss procedure, are very good. Even more than 90% of the patients are happy with it. One of the advantages is, as I said, it's possible to perform it after failed surgery, failed open surgery, failed ravage. A second operation for bar removal is a disadvantage, of course, and metal allergy can be a disadvantage, but it's possible to overcome it by using titanium bars. The bars can beep at X-ray machines at the airports, so we always give the patients sort of a card saying that they have a metal bar in their body, and it's signed by us, and they carry it in their wallets actually, and with the phone numbers and everything. And a CPR is can be problematic in these patients. Luckily, these are young patients; they don't really have a lot of cardiac arrests or anything. As long as they don't have accidents, we tell them riding motorbikes can be risky, as they're young guys mostly. Compressing the chest wall is almost impossible. So for these patients, defibrillator pedals should be placed on the back, and even the CPR should be done from the backside. I go on with carinatum. It's called also as pigeon chest or keel chest. It's the protrusion of the sternum. It can be chondrogladular or chondromanubrial, but with the minimally invasive or Bromson procedure, we only correct the chondrogladular type carinatum. It's the second most common deformity. It's again a cosmetic and psychosocial problem. So the again indication is cosmesis. Ravage sternoplasty is the classical approach for this deformity, but since the early 2000s, Bromson, who is a surgeon from Argentina, Buenos Aires, as he was inspired by Donald Nuss's technique, he described the Bromson procedure for the correction of carinatum, and we have started performing it since the early since 2006, as I said before. So we have an instrument for that, to decide what to do on these patients. It's a simple instrument. We do a compression test with it. While the patient is leaning on a wall, we compress the sternum, and this instrument measures the pressure. So if the pressure is very low, that means the chest wall is very flexible. That means maybe this patient may benefit from bracing. If the pressure is very high, over 25 kilograms per centimeter square, that means the sternum is too rigid. So a Bromson procedure is almost impossible. This patient should go on with an open repair. And if the pressure is between 10 to 25, that means it's flexible enough for a bar to compress that sternum. So we go on with the Bromson procedure. It's, as I said, it's another, it's an minimally invasive technique again, but this time you don't need a thoracoscope. You don't need thoracoscopic guidance because you don't go into the thoracic cavity. It's mostly a submuscular, subcutaneous procedure, so you don't need a thoracoscope. The bar is placed presternally, and the cosmetic results are quite satisfying again with this technique. The preoperative evaluation is almost as same as the pectus excavatum. Patients are again on the supine position, intubated with a single lumen tube. Arms are open on both sides. As we don't use a thoracoscope, you don't have to hang the arm. We always use a bar and 2 stabilizers on both sides. We have Professor Yüksel actually. First, we started doing this procedure with the classic Excavatum bars, but then it was a bit difficult to stabilize them on the ribs. So Professor Yüksel designed bars that are easier to stabilize. Actually, easier to stabilize the bar on the stabilizer with some screws, as you see here. And then, as time goes by, he changed the design a bit, making it easier to stabilize. So this was the first generation bar, and then this was the second, and then this is the third generation bar. Now we use bars like these. We don't even have screws now. We only have those small pins, which makes it so much easier than the screw. Of course, we have to stabilize the stabilizers on the ribs. On both sides. We again mark the highest point of the deformity that the bar is going to go through that line, and we make we choose 2 ribs, 2 parallel ribs on both sides to fix the stabilizers, and then while compressing the sternum, we choose the size of the bar with a template. We shape the template, and then while one of us is bending again the bar, the other one is making the incisions. You dissect through the muscles and get to the ribs. You open up the periosteum and go around the ribs with hooks or doyens, and then we place a suction catheter around the rib, as we're going to encircle the rib with a steel wire or a pioneer cable. We don't want to penetrate the pleura. We don't want to cause a pneumothorax, so we encircle the rib with a suction catheter, and then go through the suction catheters with the steel wires. We do that on 2 parallel ribs, and then place the stabilizers on both sides. Then we use a chest tube, as you see here, with a trocar. We do the tunnel, a submuscular, subcutaneous tunnel with the chest tube, or sometimes you can use the introducers of the set of the Excavatum introducers, and then we use the chest tube as a sort of a guide to pull the bar through the tunnel. This time you don't have to rotate the bar; it goes directly in its shape. And then while one of us is compressing the sternum with the bar, the other one is screwing the bar onto the stabilizers. And then we fix the stabilizer on the ribs with the steel wires. And if we need to bend the edges again, we use the hand benders to bend the tips a bit more. And then we close the sutures. In some other centers, they do this procedure with some other bars that they design. Actually, this is from Korea. There are different materials to fix the stabilizers to the ribs. This is from Switzerland, Gregor Koher from Bern. They use fiber tapes instead of steel wires. And we use, and in some centers, in other centers also, a Pioneer sternal cable. This is a cable for sternotomy. It was designed for sternotomies, but we use them to fix the stabilizers on the ribs also. They're more durable than steel wires. Steel wires may break. Pioneer sternal cables do not. So postoperative care is, again, like the Nuss procedure. We want the patients to return to full activity as early as possible. We keep the bars in place at around 2 years again. And the patients are really satisfied with the result, even more satisfied than the Nuss procedure, actually. Here are some examples from our patients. This was a 13-year-old boy. This was a 15-year-old boy again. As I said, we always place one bar, never 2 or 3. A 15-year-old patient, a 17-year-old patient, and another 17-year-old patient with carinatum.
Korkut, sorry for an interruption. There's another question in the chat. Allah's asking if you fix the stabilizers at 2 ribs or at 1 rib and around the rib, or through it, please.
2 ribs, of course. Let me go back to this. As you see here, you have to encircle 2 ribs with a steel wire or a sternal cable. And the stabilizers has holes on both edges, you see. And you have to fix the stabilizer on 2 parallel ribs. Is that clear enough? I hope so.
Have you ever tried to drill a hole in the rib to put the stitches through?
No.
To avoid a compression of the nerve?
No, because then you have to have another design for the stabilizers. And actually, we never had any, let's say, chronic pain or anything with this procedure. Maybe using fiber tapes, as Gregor Koher do, maybe it's less traumatic to the nerve. But we never thought of drilling the rib. Maybe that there's too much pressure here, and maybe it can be too much for the ribs, and drilling them can cause rib fractures. I don't know.
Okay.
Should I go on?
Sure.
We may have complications, of course. You can always have a pneumothorax while trying to encircle the ribs. You can puncture the pleura with the steel wires or the instruments. Steel wires can be broken. The bars can be dislocated from the stabilizers, as you see here on this X-ray. Cutaneous adhesion can be a problem. So we advise the patients to have a local skin massage on the bar. Allergy is always a problem, and insufficient correction or overcorrection can be a problem. As you see here, the patient is now suffering from pectus excavatum, a iatrogenic excavatum, let's say. We have published several papers with our technique. And of course, there are other institutes doing this procedure, publishing their own results. And this is the paper as a review published recently in 2021 on our Bromson procedure. And as a last technique, I'm going to talk about the sandwich technique or press molding. This was described by Hyun Park. He's a famous pectus surgeon from Seoul, Korea. When simple external compression is not enough for pectus carinatum, or deformity is asymmetric, or it has the deformity, or if the deformity is a combination of excavatum and carinatum, he described this technique, and he offers this technique to be performed. We rarely use this technique also. In this technique, you place two bars, one excavatum bar and one carinatum bar. The carinatum bar is pushing the highest point downwards, and then the excavatum bar is pushing the deepest point upwards, and it can provide good results in asymmetric patients, as you see in this picture. This is from Kuhn Park himself. He corrected this deformity with two bars, one a Bromson bar, one Nuss bar. We also have some patients. I only want to show you two patients from our clinic. Both were corrected with the sandwich technique with two bars, one retrosternal bar, one presternal bar, and the results were actually good. This is the end of my presentation. Thank you for your patience.
Korkut, thank you very much. Very interesting presentation as expected. I think there might be some questions around here, so I would like to get the audience to pose their questions now, and we will try to answer them. You try to answer them, and I think maybe the panelists have questions as well. So the first question here is from Carlos. He wants to know, what is your age limit when doing this procedure? Is there an upper age limit?
Actually, no. I personally operated. My oldest patient was 46, but I know Professor Yüksel operated even a patient who was 55 years old. And
do you look
this is
for
really
any classification?
This is really a psychosocial problem, you know. Like sometimes those patients are really obsessed with their deformity, and even if they are married, having kids, and having a good life, whatever, they may really have to have it corrected, even if they are 50 years old.
Okay, so do you look for any calcifications in the CAT scan?
In the older
It's
patients.
one question. Do you look for any calcification in the CT?
Calcification of what?
Maybe Carlos can write something further. That's what he wrote.
Yeah, before removal, we look for that, if that's the question.
No, on the cartilages, he means.
No, we don't. No.
Okay.
No.
Okay.
Nothing can stop us if a patient wants to.
All right. So another question from Ala. I'm not sure if he is a she or she is a he, sorry. How do you deal with infections? Do you remove the bar or do you keep it?
We try the best not to remove the bars. We give antibiotics. Sometimes it's really difficult to distinguish between an infection and a metal allergy, because metal allergy patients have a lot of drainage and everything, seromas. But if it's really a problem, we had to remove some bars earlier than planned because of infections, but very rarely.
I would like to go back to the topic of allergy. You said, do you do any preoperative testing for allergies, or and if yes, how you do it?
Actually, we question the patient, and we have small nickel plates, and we stick those plates on the forearm of the patient. for a couple of days, and that was what our dermatologist advised us to do. It's very simple. If the patient is female, we ask them if they have problems with their jewelry, their things,
Okay.
but we don't really do more sophisticated things.
And how frequent is the use of titanium bars in your department?
Now we use routinely titanium bars.
Routinely, okay.
Yes, there's a local company, Turkish company, producing titanium bars, and they're not really very expensive. The hospital have bought them, luckily, and we routinely use titanium bars for the last few years.
Okay.
So what kind of bars do you use, Sönke?
So we had no problems with this allergies, and we use the standard ones.
Okay.
But we also only do we ask the patients for allergies, but so far we had no problem. And as our dermatologist told us that the allergy is typically it's a skin allergy, and so if you go under the skin, you have no problem from the bar as long as they're far away from the skin. So maybe that's the reason why it's in the Apparatus procedure a bigger problem than in the Nuss procedure.
Yes, so let me tell you this: the opinion to the topic of allergy is very different under dermatologists and even under the thoracic surgeons, or pediatric surgeons. This is what Sönke said. So there is no contact to skin, so why allergy? So we never saw any real nickel allergy in any Nuss procedure. So over 1,000 cases, we never saw. So I remember one comment from Nuss many years ago, and he said, "Oh, the topic of allergy is you have a complication or you have infusion, and there's a easy and fast explanation for this complication, but actually is not really an allergy problem. So you must have the symptoms of allergy in both sides of the chest, not only in one side. Otherwise, there's no allergy." So and we get very strong letters from dermatologists even when we ask for testing. So the company Zimmer or former name of the company, the Lawrence company, first advised to test with the small piece of the same material for skin testing. But this skin testing is not advised anymore, because the dermatologist said maybe you induce the allergy with this test. So what we do is, when we get any advice from the patient, oh, I have reaction to a chain or to the watch or what else, the belt, any skin contact, then we advise the titanium bar. But to operate with titanium bars is so different to the normal bar. So many new things you have to keep in mind with a titanium bar. You can't bend it like the normal bar, and there's so many different things. So it's a very complex question. Yeah, but we never saw any really allergy to the normal bar.
So, Korkut, how is it? What's your experience in bending the titanium bars?
Of course, they're a bit harder, but we use the same instruments to bend them, actually.
Oh,
just stronger muscles.
Yeah, maybe.
Okay, there's another question from Carlos, and we are moving to the complications and nightmare discussions. He had a patient with a laceration of the right ventricle as a complication of bar removal. He's asking if you have ever seen that before. Hopefully not.
Yes, we did. Not during bar removal, but during while doing the tunnel, creating the tunnel. And actually, our first cardiac puncture was during a workshop. So there was a live transmission from the OR to the conference hall, and yeah, we punctured the heart. Not one hole, even two holes. We went in and went out. So everybody in the audience was shocked, us of course. It was Professor Yüksel's 100th case, so we were quite experienced actually. And of course you have to call the cardiac surgeons, as we are pure thoracic surgeons, we're not cardiothoracic. I don't know if you are cardiothoracic, but we had to call the cardiac surgeons. We had to open an anterior thoracotomy as fast as possible, and the two punctures were sutured by the cardiac surgeon. Luckily, we didn't have any complications afterwards. But yeah, that not while removing the bar, but while placing the bar, and we had it twice. The other patient was a redo case who had a ravaged sternoplasty before, so he had some adhesions. This time we saw that we are puncturing the heart, so it was a bit more controlled. We again had to call the cardiac surgeon, and he placed the suture through our. He managed to place the suture through our incision.
Okay.
So the first one was really catastrophic, but yeah, the second one was a bit more controlled. But I know that some people experience cardiac lacerations while pulling the bar. You saw the bars with bony tissues at the tips on my pictures. So that's why it's better to open both sides of the both incisions on both incisions and release the tips of the bar as much as possible. If you open one side and try to pull the bar from one incision, it's always possible to have a bit of bony tissue coming together with the bar, going all through the tunnel and lacerating things maybe. It doesn't have to be the heart itself, it can also be the mammary artery also.
So when I did that procedure on the Brompton, they always had a transesophageal echo probe during the procedure in. So you can see the bar going between the heart and the sternum. Do you think this is useful, or is this just playing around, or?
That's too much, I think.
Too much.
You have your camera. You have your camera, endoscopic camera, and this is the advice. You have to see always the tip of your throat, where you are going. This don't operate blind. You never operate blinded. Yeah. So then my advice is, when the question was bar removal, always open both sides. Yeah. Nobody ask if you have a strong laceration. Remember, it's around 8 or 10 years ago, there was 2 catastrophic complications in Britain. And the follow-up was the society give a lot of statements that in Britain they can continue with a Nuss procedure because of these complications in bar removal. This was an injury of the aorta ascendens. So we always open both sides, remove the bony tissue. For instance, in the young patients who are very active in sports, they have more this of the bony tissue around the bar. And there's one other thing. Nobody will mention this because the Nuss procedure is the state of the art is not. So you can't correct all the deformities with Nuss. Yeah. So you have also this bony overgrowth surrounding the bar and connecting the ribs each other. And you remove the bar and have still problems in place. So you have seen patients from 1998, from the beginning, when they started in US, and there was 4 ribs connected with bony tissue, was 1 plate. Terrible complication in the years afterwards. So, and for bar removal, always open both sides of the bar. I remember this advice from Nuss himself. And there was one meeting, it was in Norfolk, and when we sit in the meeting, it's not in the audience, you know all this, the tips and tricks you hear at the dinner side. So many tricks when you get any bleeding come out from the tunnel, from the bar, what is to do to stop the bleeding. So then when you open both sides, test how is the bar going, easier to right or left. And then keep in mind when you take it out, oh, which side of the mammarian artery can be the cause of the bleeding if you have a bleeding. So, and which side you jump in and make the correction. So this is a lot of experience and to see what can happen. But we also, when we have 2 bars in, before I bring out, remove 1 bar, both bars are free. Imagine you have a bleeding. When you move the first bar and the second bar is still fixed and you must open. Happily, we have never this case, but when you visit your colleagues in the meetings, you hear this complication and this complication and this, and then with all this information, find your safe way. This is it. Nuss procedure is minimal invasive in the first step, but bar removal is not minimal invasive at all. Yeah, this is it. So all this bony overgrowth is only to explain to the audience, because we see more and more and more re-ops from Nuss procedure. This is it, what we have to discuss.
Yeah, I think that's a very good point. As Korkut said, he's mainly using the short bar technique from Hans Pillegard. And as I know, you are a fan of the long bars, Ronald. So are you straightening them up at the end of the, are you straightening them up before removal, or are you rolling the patient?
No. So we bend up the bar on each side a bit. Then we test the bar, it is going this side, and then we follow the curve from the bar. And when this is not possible, that we come in action with a table, then we lift up a bit the patient. Yeah, then to rotate the bar out. And the problem is when it's not going the last step, and then you can get any bleeding on the intercostal artery or whatever. It's almost going very easy and fine. Yeah.
And I think another very important aspect or a point is, and I hope you two agree, never to flip back the bar.
Yes.
Straight them up, but never do a backflip while bar removing. Maybe at the time of primary operation, if you just a minute after insertion or 5, but not 2 or 3 years after removal. Never flip them back.
This is right. It's right.
There's one more question about just a very different topic again, or point of view about the antibiotic treatment or prophylaxis after operation. Are you doing it routinely, Korkut?
I mean, we don't do it anything specific for this operation, but for all our patients, all our lung operations, everything in our clinical practice, in the practice of our clinic, we always give the patients antibiotics 1 day before and then 1 day after surgery. So we don't do anything specific for Nuss procedure.
Just a short perioperative antibiotic treatment.
Can we come back to that aspect of blind surgery? Because I agree that you need to see what you're doing when you put through the sword into the cavity between pericardium and the sternum. But what about the other side? When you go across the midline, then you will definitely lose your vision because you're on the other side. So
No, you see everything.
Yes, yes.
do you follow your sword with the telescope into the
Yes.
other side? Do you see the lung of the other side as well? Oh, okay.
And then remember, there is a ground technique, yeah, the ground technique from Park, and you also can use only a small hooky to bring it.
Right.
And even so we are thoracic surgeons. We don't operate the small children. This is not to compare. To operate an 8 or 10-year-old boy, this is a complete different operation to a man with 30, 40, 50. This is, how to say, this is compared to Volkswagen to Mercedes. So not to blame Volkswagen, but the level is completely different. Yeah, the chest is so strong, and then you come to a point where there is a limit for the Nuss technique. This everybody must realize. There is a limit for Nuss technique, and even Mustafa create a lot of new devices and tricks when I met him last in Norfolk. So then you can bring the age from the patient higher and higher with all these tricks and new devices. But then the result is more and more pain for the patient and more tension in the chest wall. So, and this we have to learn to accept. Where is the limit for one technique? Yeah, this is it.
In the preparation for this talk, I found a couple of papers telling that they do the thoracoscopic view from both sides. So they had an access with the telescope from the right side where they introduced the introducer, and then during that phase they actually switched to the other side with the camera and looked from the other side. Is that something that you think you need to do, or limited to very special cases, or you never do that?
Well, if you're asking me, we never do it. We use a 5mm lens and we follow the introducer to the other side till the very end. We can even see the other incision sometimes. So why we should need to go to the left?
Okay,
That's right. The same. We always start from the right side. But I think important is the level from the entry point. So more to the anterior line, or what we saw in your video, Korkut, was right in the around the mid-axillary line. When you have a deep funnel, this can be difficult to follow the channel from the bar. Yeah, or you use the special camera from Park. He has the camera in the tip from the sword. So
Pectoscope.
Yeah, from the pectoscope. That's right. Thank you. This is the name. Yeah. So, but finally, you must train with one technique. If you jump from one technique to the next, what you saw on the last conference, then you will always be the beginner with a new technique. Yeah. So decide for one technique. So the musician always uses his instrument to be perfect. You can't always change the instrument when you go on stage. So use your technique. And when you are perfect with this, start to give in your variation. This is my opinion. So, yeah.
Okay, we have some more questions.
Entry point is important to see and follow this word. This is it.
Okay, thanks. We have some more questions from the audience. Are there any special considerations for patients older than 16 years?
Special. I mean, as the patients get older, you may need to use more. The number may increase. The number of the bars may increase as the chest wall is more rigid. but nothing more actually. There's another question related to this I see on the side. What's the relationship between the age of patient and time removing the bar? So as if the patient is younger, we keep the bar up at around 2 years, but if the patient is older, around 30, 25, yeah, we may keep it for 3 years, sometimes even for 4 years.
And somebody wants to know how many cases you solved with your sandwich technique.
See, this guy is asking it to all of us, as I
maybe
not many actually, not as much as Park does, not as many as he does. We most of the times we solve the problem with either Nuss bars or a Bromson procedure. We rarely do the sandwich technique. We may even do an open surgery for those patients sometimes.
And what do you think of the vacuum bell in cases for pectus excavatum? Are they effective?
We use them too in younger patients, because sometimes we see patients, 7-year-olds, for instance, and if the chest wall is very flexible and the patient is young and the family is not willing to have a great, and of course these patients read a lot. The families go through internet, check Google, they know everything. Sometimes they come asking for a vacuum bell. So yes, we sometimes give patients vacuum bell, and then if it works, if it works, it works. If it doesn't, we go on with surgery. Some surgeons use it during the operation. You know, we do. I don't know if you do it, but we don't. Sometimes some surgeons use it to elevate the sternum while going between the heart and the sternum, but we don't. We also use bracing for carinatum, as I mentioned during the presentation. Also, if the sternum is very flexible, we can go on with bracing first.
Are you using the crane technique frequently or never, or?
Never.
Never.
Do you use it?
No. But there are opinions in the society that said you must use it, otherwise it's too dangerous. But I'm close to Ronald. The most important thing is you must see all the time, not mostly, all the time. You must see what you are doing, and you must see the tip of your sword. And as Fabian has mentioned in the chat or in the F&As, they routinely switch the camera to the other side. So in my opinion, it's not necessary. But if you can't see for any reason, it's much better to move the camera to the other side than to go on blindly.
There's another question from Fabian here. What is your advice about going back to sports after a Nuss procedure for the patients? What kind of a break should they take?
We tell them not to do active sports for the first month only. And other than that, we want them to return to full activity as early as possible.
And this includes like contact sports, like
No taekwondo.
So mixed martial arts is not the sport for the Nuss procedure. Okay.
No kicks on the chest wall, please.
Okay.
Actually, we had a patient, not with Nuss procedure. When I was a resident, it was an open procedure. It was a ravage. You know, you place some short bars in ravage too sometimes, and you remove them after 6 months. That was how we were doing it when I was a resident. And this guy, 17-year-old, he didn't come for the bar removal after 6 months, and he did martial arts. And his bar was broken, and the one part of it was in the heart. So we had to remove it by a sternotomy, and it was like a major cardiac surgery, and we even published it.
But there is no report there for a broken bar from Zimmer or the original Nuss bar. It was never broken. I know no report that this was happened. And we advise the patients for normal activity, walking, training, go the stairs up, and after 8 weeks, they can normalize the activity completely, step by step. And we talk about bar removal. So you see how strong the bars are fixed. So after half a year or year, the bars are more an inner protector. So we have patients in special forces. We have patients in trophy sports with the bars inside. All activities and the result from the reshaping or remodeling process is much better in active patients. So do sports as much as possible. Football, basketball, all is possible. And the result and the reshaping for the chest is much better than to sit on the dashboard and work at a computer site. Yeah.
Does this include like bodybuilding as well?
Yes, bodybuilding as well. So this not from 0 to 100 when you start the activity. Yeah, but this we when we say this, we come back that the illness of Pectus disease, in my opinion, is not only cosmesis. Yeah, it's not only a cosmetic problem. And if you ask the right questions, all the patients will explain you, oh, I never know what is normal because I grow up with this. But they all have the experience that they were very good in sports, team sports. And then the pectus developed. And from the best, they go through to the last position. So the endurance activity is terrible. So we know all the reports from the compromised heart function from funnel. So Hans Pillegard and his team do a lot of reports. So people are not able to increase the volume, the minute volume in the same way like a normal person. So this is the problem, and they all react with tachycardia. This is the chance to increase the volume. Yeah, and when we say this is only an aesthetic problem, of course we know all the unit from aesthetics and function. Yeah, but when we say this is only aesthetic, we will all have problems with the health insurances. So we have to show and prove there are limits in the activity. This is the problem, and this we deal with very seriously. Otherwise, we will never get the permission from the insurances for the operation. So we must show very hard. These are the problems. What is the patient complaining? Not only that there's a sunken chest, yeah, that are psychological problems too. This is normal. So the interaction. So the first experiences in love end. So the experiences can be terrible for the patients. So one of my oldest patients was 64 when I operated him because of heart disturbances, untreatable heart disturbances. And then the cardiologist said, oh, maybe it's the funnel. So we corrected, and finally the problem was solved. So keep all this in mind. We all know as a thoracic surgeon, in lung resection, you deal and give tension on the lung veins, and you can create the disturbances. You understand what I mean? So when the cardiologist take his catheter and make the ablation is around this area inside the entrance from the vein to the atrium. But the funnel chest shift the heart to the left and create all the tension exactly in this area, where in other accepted illnesses, the disturbances localized or the origin. So, and we must realize that this illness is much more than cosmetics. And when we are looking inside, then we see, oh, this is the reason, this is the reason. And we all see how the capacity for sports is much better after operation. This is the best in this field. You see all these young patients over years, and how the life is coming up, the life is coming back. Yeah, the patients come and introduce the wife or this, so completely changement of life. And this we must realize, what we are doing, not only to repair a sunken chest. This is much more.
Yeah, I agree. Always a psychological problem to the patient, and they're really changed after the surgery. Yeah, I would agree. So, any of you, do you have any experience with custom-made implants?
No, not
This
for the
one
Nuss
is one of the questions.
Yes, we have experience with this to take them out. Yeah, this is it. So sometimes we see very good implants. I saw, it's not long ago, I saw a lady who has this implant nearly 30 years, was well done from one plastic surgeon. But in the end, the physiology of funnel chest is not cured. This is only cosmetic. This is aesthetic correction, not more. Yeah. And then in man it's very difficult to make an implant. You always will see the border lines and movement, and then it's a problem. Yeah.
Okay. So any of you experienced pneumothoraces after removing the bar? One of the other questions here.
No. When we remove the bars, we sometimes look with not sometimes, we look with the scope in the tunnel, as Roland and Korkut said before, but we are normally not looking in the thoracic cavity, and so we haven't seen that, but we check it by X-ray before discharge.
Yes, we do also.
There's one advice for the audience. All these young patients are tall, typical pneumothorax patients. So independently from the funnel chest, you have removed the bars, all is fine, and the patient will get pneumothorax. So keep in mind that there can be always a small connection from one chest to the other in the area where the bar was placed. This is possible. And then we saw cases where the patient got pneumothorax, but then on both sides. It's not often, but it's possible. And this you must keep in mind.
Okay. So any of you have any experience with Pactus up technique, and could it replace the Nuss way? Another question from Salem.
I only know what it is, but I have no experience.
Same with me. I've seen the theoretic procedure, how to do it, and I'm a little bit afraid of screwing, of putting a screw from ventral side in the sternum to lift it up. But I have never practiced.
No. And any of you have seen the bar migrating to the abdominal wall? There's another question. No.
Into the pleural cavity, yes, but not
to the abdominal. All right. Anything else you would like to mention, Sönke, Roland, or Korkut?
No?
No,
It's a pleasure.
I think we're coming to an end now. Most of the questions seem to be answered here. So I think we need to close this session. Thank you very much for coming, Korkut, Sönke, and Roland. Very interesting, especially for me, since I'm a surgeon, thoracic surgeon, mainly focusing on oncology work. So everything was new to me here. So thank you very much. I learned a lot and hope the audience did too. I can tell you and announce that all of the episodes from the Mind School will be on YouTube very soon. So if you want to recheck that, you're able to do that, and you will all get the URL, the address in the web via email as well as you will get the invitation for the summer edition, the 4 additional episodes I announced already. You will get that via email again and via LinkedIn. So I would like to close this session. I would like to close this series of the Mind School. Again, a warm thank you to all of the participants, to all of the panelists and the presenters, and to the societies, the German Society, the Turkish Society, the Colombian Society, the Mexican Society, the Argentine Society. I hope I didn't forget anyone. And to the sponsors as well. And I hope to see you all again, maybe in some kind of a in-person congress, or at least to the summer school. Thank you very much, and thanks for having us. Bye-bye, take care.